Good morning, everybody. I would like to welcome you on this talk about Crohn's disease and IBD, where surgery meets gastroenterology. My name is Philipp Schreiner. I'm attending physician in the Department of Gastroenterology, and this is Dr. De Cavallo Fischer. She will present you the latest data on this topic, and we try to make it also interesting for you as surgeons and not only for me as gastroenterologists. So enjoy the talk.
Thank you. A short recap: Crohn's disease is an idiopathic inflammatory disorder of unknown etiology. It is in most cases a chronic, progressive, and destructive disease, as evidenced by the graph below, where we can see how disease progresses based on the Vienna classification within 5 years. What we can also see is that patients in Western Europe tend to have more advanced disease than those in Eastern Europe, which suggests that environmental factors also play a role in disease behavior. So patients will commonly present with abdominal pain, with diarrhea. This can lead to weight loss and growth failure in younger patients. And it's important to remember also that Crohn's disease can lead to extraintestinal manifestations, such as erythema nodosum and ankylosing spondylitis. So this question goes out to our students. What part of the gastrointestinal tract is affected by Crohn's disease?
It affects the entire gastrointestinal tract?
Correct. That was a trick question on my part. So Crohn's disease can affect the entire gastrointestinal system. However, population studies have shown that patients will present with either disease in the ileum, ileocolic disease, or colonic disease in 1/3 of cases each. And the interesting part about this is that only a minority of patients will develop a change in disease location, as we can see here in this wonderful diagram. L1, again using the Vienna classification, is ileal disease, L2 colonic, L3 ileocolonic, and L4 is disease of the upper gastrointestinal tract. It's important to say that patients with proximal disease are more likely to develop complications. So Crohn's leads to an asymmetric transmural granulomatous inflammation of the luminal GI tract. That was a lot of big words. Essentially, we see this in this section below, where we can see a granulomatous formation and also lymphoid infiltrates. Diagnosis involves a combination of tests, depending also on what the patient presents with. However, an ileocolonoscopy is mandatory. And this is a so-called cobblestone appearance of the luminal GI tract in Crohn's disease. Now, medical treatment of Crohn's disease involves different drug classes. Corticosteroids can be used to treat an acute exacerbation of disease. Inhibitors of DNA synthesis, such as thiopurines, azathioprine, 6-mercaptopurine, and methotrexate, can be used to maintain remission. Antibiotics like metronidazole or ranitazole play a role. We'll get into that later. And 5-ASA drugs have lost importance in this setting as they are less effective. Finally, biologic drugs, namely anti-TNF-alpha agents, are very important in the treatment of Crohn's disease. Another question for the students: who can name an example of an anti-TNF-alpha agent?
That would be infliximab and adalimumab.
Great, thank you. Another one is certolizumab, but that was completely correct. Now, indications for infliximab treatment would include unresponsive Crohn's disease, refractory fistulizing Crohn's disease, or even induction therapy or maintenance therapy for more moderate to severe cases. Then there are other biologic drugs, such as ustekinumab, which inhibits interleukin 12 and 23, and vedolizumab, which is an anti-integrin. Now, this question goes out to our surgical residents. How often do you guys think that Crohn's disease patients require surgery?
Maybe about 50% of patients.
Perfect. That is exactly it. So the 10-year cumulative risk of major abdominal surgery is 40 to 55%. Recent studies have shown that in the biologic era, this may have decreased to 30% about. However, up to 35% of patients who have had surgery will need another surgery at a later date. Another question for our residents: common surgical indications for Crohn's. We'll keep this short because my colleague will be holding a talk next week on the subject. Who can name some?
Perforation or fistula or persistent abscess?
Very good. So firstly, intestinal obstruction, a stricture or stenosis, then penetrating disease, which are the examples you just named, failed medical treatment, or last but not least, malignancy. What about surgery as a first-line therapy and curative intention? That's what the LYRIC trial in 2017 looked at. That was a randomized controlled trial that compared laparoscopic ileocecal resection for limited disease versus an infliximab therapy, and showed that surgery is a cost-effective treatment with similar quality of life. Then there was a follow-up, the results of which came out this year, which looked at both groups over a longer time and compared outcomes. They were able to show that the duration of treatment effect was the same in both groups, meaning the time until patients needed an additional therapy was the same. However, of those patients in the resection group, none required a second resection, whereas the patients in the infliximab group, 48% required a surgery at a later date. So I'd like to present a case to get us thinking about this. We have a 27-year-old male with episodic abdominal pain, nausea, 3 to 4 liquid stools daily for the past year. We performed a colonoscopy, saw a stenosis of the ascending colon, and performed an MRI of the small bowel and saw a circumferential wall thickening of the terminal ileum and ascending colon. He also had skip lesions in the ileum and jejunum. So we studied him on corticosteroids, and at a later date, he got an anti-TNF-alpha agent, infliximab. Months later, he presents to the emergency services with fevers, chills, and nausea. We perform a repeat colonoscopy. It still shows us the stenosis in the ascending colon. We determine, along with that and other results, that he has had an insufficient response to therapy. And he gets planned for surgery, receives an ileocecal resection with side-to-side ileocolic anastomosis, small bowel segmental resection, and stricturoplasty. Now, what do we do with the immunosuppressive medication? So our first question has to be, what's our goal? Goal number 1, we want to minimize perioperative complications such as an ostomotic leak or septic complications, bearing in mind that the overall complication rate described in the literature for Crohn's disease patients is high. We also want to prevent recurrence. So clinical postoperative recurrence in patients who undergo major abdominal surgery is 30 to 50% within 5 years, whereas endoscopic postoperative recurrence is about 70 to 90% at the anastomosis within 1 year. So minimizing complications, there were a couple of studies on this. Norgard conducted a nationwide cohort study, discovered that rates of bacteremia and ostomotic leak, reoperation, and death do not differ between patients who had an anti-TNF-alpha inhibitor or an agent before the surgery and those who didn't. The interval between the anti-TNF-alpha dose before and after the surgery did not influence the postoperative outcome. Then the Puccini trial is a very recent trial that tried to identify risk factors for postoperative infection in Crohn's disease postoperatively. They found that infection rates are similar in anti-TNF-alpha exposed and unexposed patients, and that serum infliximab and adalimumab levels were not associated with infection. So Puccini here, the composer, is here to remind us that the full text publication is still pending on this. And we currently only have the abstract, so we should keep an eye out. Now, Bouquet et al. Also looked at this subject and unfortunately came to a different conclusion. They determined that anti-TNF-alpha therapy in the 3 months before a surgery is an independent risk factor for overall postoperative morbidity. In essence, we don't know. The evidence isn't sufficient, and hopefully the Puccini trial can help us a little bit with that. On to the second subject, preventing recurrence. There are risk factors that tell us that patients might develop a recurrence after surgery, such as a young age under 30, a shorter disease duration, prior resections, or fistulizing penetrating disease. A very recent study also suggests that the patients who are colonized with fusobacteria tend to recur more often after a surgery, which tells us maybe the intestinal microbiota also plays a role. the most important thing is the only modifiable risk factor in postoperative clinical recurrence is smoking. So we should all remember to counsel our patients that it's time to quit. And now De Cruz carried out the POSER trial. The POSER trial was a randomized controlled trial that compared patients who had an endoscopy at 6 months after a surgery and then had their treatment adapted based on the results to those who only had an endoscopy based on clinical suspicion of recurrence. And they found out that active care, so an endoscopy at 6 months and treatment adaptation, was better than standard care. So patients developed less recurrence, and so we learned from that that patients should have an endoscopy 6 to 12 months after the surgery. Another analysis looked at high-risk patients within the POSER trial cohort, so smokers, perforating disease, previous resections. They received metronidazole and a thiopurine in one group, and the other group received metronidazole and adalimumab. They were able to show that adalimumab, the anti-TNF-alpha agent, leads to less endoscopic recurrence at 6 months versus the thiopurine. However, there was no difference in clinical recurrence, potentially because the trial wasn't conducted, the follow-up wasn't long enough. Gairu et al. Conducted the PREVENT trial. This was a multi-center, double-blind RCT comparing infliximab versus placebo for postoperative recurrence. And also here, they were able to show no big difference in clinical recurrence, but a significant difference in endoscopic recurrence. Now, Rutgers is an important name in Morgan's Crohn research. He conducted a double-blinded randomized controlled trial comparing metronidazole to a placebo in patients who received an ileal resection with a primary anastomosis in 1995. And he found that patients with metronidazole had less recurrence than those who didn't have metronidazole. Then he conducted pretty much the same trial 10 years later with ornidazole, and also found that ornidazole, as a prophylactic treatment for recurrence after a ileal resection with ileocolonic anastomosis, is an effective treatment as it reduces clinical and endoscopic recurrence. Glick published a study a year ago on low-dose metronidazole used for preventing endoscopic recurrence after ileal resection, and he was also able to show that low-dose metronidazole led to significantly lower endoscopic recurrence within 12 months than a control group that did not receive metronidazole. So now we've learned a lot from the literature. What do we actually do? Before the surgery, we try and hold the anti-TNF-alpha therapy with the goal of missing only one dose. We can also schedule the surgery between doses of the anti-TNF-alpha drug. We continue immunomodulators, and we taper corticosteroids to a minimum. Our patient then goes to surgery, and after surgery, the first thing we do is we schedule an endoscopy 6 to 12 months after the surgery. In the endoscopy, the gastroenterologists will conduct the Rutgers score. So Rutgers should by now be a familiar name. And endoscopic recurrence is defined as I2. So I2A are lesions confined to the anastomosis, and I2B are more scattered aphthous lesions or larger lesions. And depending on the score that they find at endoscopy, the gastroenterologists will adapt treatment. Now, it's also important to stratify our patients into low-risk and high-risk patients. So high-risk patients, again, younger patient smokers, those who have had previous surgeries, have a higher risk of recurrence, and it's pretty much given that they'll have endoscopic recurrence. So a low-risk patient would receive metronidazole, 250 milligrams, 3 times daily for 3 months. If they are intolerant to this treatment, another option would be ornidazole. And here at the University Hospital of Zurich, we perform an ultrasound and calprotectin at 3 months to identify early recurrence. If there is no indication for early recurrence in the ultrasound and calprotectin, we go on to a colonoscopy at 6 to 12 months. And depending on the results, treatment is adapted. For a high-risk patient, they will be started on anti-TNF-alpha agents beginning 3 to 6 weeks after resection. Immunomodulators, vedolizumab and ustekinumab can also be considered in combination or on their own. And then the rest of the path is similar. So that was that. Thank you for listening. Have a wonderful day.
Well, thank you very much, Cynthia and Philip. Excellent presentation, very rich presentation, a lot of information that you gave us, a lot of food for thought. Any questions from the audience? Well, I do have one, and that relates to the LYRIC trial. When looking at the newer data from the LYRIC trial, one must just wonder if, on a more global scale, we're doing things right with this disease. It appears to me as if the solution to new onset Crohn's disease of the terminal ileum, which is the most common of all the variants that we see, is best solved by early surgery, which is exactly what we're not doing at this point. But instead, and I try to be a little placative right now, is we're developing new expensive medications which we use in sequence in trying to get our patients to a medical remission, which takes years and years and years, and at the end of all this, patients will be sent to surgery in 50% of cases. So how can we justify this to patients, and should we not rethink, according to this large and well-conducted trial, and start offering surgery as a first-line treatment to patients to begin with?
Yes, I completely agree with you. I think we should offer the patient the operation. However, I have to say two things. First of all, these were a highly selective group of patients. So they had a non-stricturing disease, only 40 centimeters affected. And the other very important point is, I think we saw it here in this slide. We just have to tell the patients, if they get an operation, yes, they have a high chance that they don't get a second operation within the next 5 years. But if you look at the graph here, 80% of the patients had therapy, and also one of the very expensive ones. So only 20% of the patients who got the operation had, after 5 years, no other medication regarding IBD. But at least it's 20%. That's true.
But still, surgery should not be considered a failure in this group of period. I think that really makes it. The study really makes a point for early surgery in patients in whom we must anticipate treatment failures long term.
I completely agree with that.
Yes, Cynthia and Philip, thank you very much. Great talk. Wonderful presented. I have a question concerning prevention of recurrence. In many of those studies, we see an endoscopy, which seems to be better, which has an advantage, but in most studies, no clinical difference. So, how liberal should we be in giving biologicals, which are quite expensive as well? How liberal should we be?
I think the question starts with this low and high risk group. So it depends a little bit. Everybody agrees that in high risk patients you should give early biologic therapies. But in all the studies and all the opinion leaders, they never say what is a really high risk patient. I think a high risk patient is only patients who smoke or who still smoke, who have who had at least one operation before, and who had a stricturing disease. And I think if all these risk factors have the patients, then he should get an early biologic therapy. All the others, if you just smoke or if you just had 2 operations of just one of these risk factors, I think you can go along with the antibiotic, with the metronidazole, for some months. But all the studies then, they show that during this time when you take the antibiotics, it works pretty fine. And after that, the recurrence comes. So this is really difficult. But I can tell you that most of the patients, if they don't get any therapy, within 5 years, they probably have a recurrence.
Maybe the one thing that we often discuss in this type of meeting is who should be taking care of these patients. It appears to me as if things get more complex every year. Medications get more complex. We haven't talked about surgery yet. Surgery is a little more, let's say, traditional, but even so, it has changed over the years. So who should be taking care of Crohn's disease patients? Is that something for specialists? Is that something that still everybody should be able to manage, simply because there's quite a few Crohn's disease patients out there? Your thoughts, Philip? You're a gastroenterologist who is developing into that type of subspecialty already at a young age. What do you think about this?
It's a very good question. We see it more often now that the most patients get referred to our university hospital, because at the beginning you can treat patients with a little bit budesonide or corticosteroids and anti-TNF, and then it gets more complicated. And Cynthia told you a little bit about the medication, and this is just the beginning. If you look at the papers from last year or 2 years ago, a lot of more biologics and now also oral small molecules will develop. So that's why it gets also for us very, very complicated. And that's why I think the complex patients should be referred to a IBD center.
So on a personal note, I find Crohn's disease to become more and more complex, and we've started having a board together with our gastroenterologists, a small group of physicians, surgeons, and gastroenterologists who meet about once every 2 months maybe to discuss the more complex cases. I personally find that very helpful, simply because we find solutions that are based upon the opinions of both types of physicians in the field. So that has been very helpful to us. If there's no other questions, thank you very much. Excellent presentation. Nice discussion.